Hello and welcome to Social Medico. Today we'll be seeing a lecture on medicine, which is from nutrition, vitamin D. Okay, so without wasting time, let's start it. So, what is vitamin D? So, vitamin D is a fat soluble vitamin, which is also known as calciferol. Okay, and 17 D hydrocholesterol, which is a chemical name, is a building block for humans. Okay, and one more thing, that cholecalciferol, which is vitamin D3, is a provitamin which is found in humans. Okay, so we'll see the synthesis, how the synthesis occurs. So synthesis, what happens is, it is already present in our skin, so which is known as 7D hydrocholesterol. Whenever a UV light or the sunlight hits on our skin, so that time what happens, this 7D hydrocholesterol gets converted into pre-vitamin D3, and then this pre-vitamin D3 gets converted into cholecalciferol. As we have already seen, it is a provitamin which is found in humans. So then it goes to the liver, and in liver it is converted as 25 hydroxylase, and whatever vitamin D from the diet and vitamin D supplements which we take is directly stored into the livers. Okay, and from liver it travels into the other, like, in between the kidney and liver, it gets converted into the calcidiol. Okay, so this vitamin D metabolite is present in blood serum, so it will be traveling from liver to the kidney, so it will be present in blood serum. So its concentration is measured to determine the vitamin D status. So whenever we are taking a serum vitamin D, so we are getting the values of calcidiol. Okay, so then it travels into the kidney, and here it becomes 1 hydroxylase. Okay, and from here kidney, it then gets converted into the biological active form of vitamin D, which is known as calcitriol. So we should know that the cholecalciferol is a provitamin which is D3, and the active form, biologically active form, is calcitriol. And now let's see the functions of vitamin D. So what are the functions in GIT and kidney? What it does, it promotes the absorptions of what, of calcium and phosphorus. Okay, so and in bone what happens, it stimulates normal mineralizations, like storing up of the calcium and phosphorus. So here we can see that this is the bone structure. Okay, so growing bone. So in the growth plate we have a condylocyte. Okay, so here what happens is, when phosphorus it enters into the apoptosis. So what happens here is, when there is a calcium and phosphorus deposition, the normal mineralization is continued, and due to which there is a hardening of bone, and the development of a baby is good, and even in the adults. Okay, so now let's look into the deficiency of vitamin D. Okay, so in deficiency of vitamin D, what happens is, see, the first and foremost, it is in children's what will happen, in children's the rickets will be occurred. Okay, so in rickets, what happens is, the vitamin D deficiency will cause, what it will cause, it will cause a developmental effect in children, which is the short stretcher, and there are other deformities, so which you can remember by a mnemonic rickets. Okay, so first and foremost, a Richet rosary. So Richet rosary is what is known as beading of ribs at costochondral joint. So we can see over here the Richet rosary. Okay, so at the costochondral joint we can see there is a beading here, right over here, and the other is pigeon chest. We can see pigeon chest, which is overgrowth of a cartilage. What, overgrowth of a cartilage where between the ribs and sternum. And then we have the other sign, which is Harrison sulcus. Harrison sulcus is a horizontal indentation on the chest that runs along the lower border of thorax. And then we have pectus craniatum, which is a breastbone and ribs are pushed outwards. Okay, and then we have a craniotapes. Craniotapes means what? It is a softening of skull bone. How soft, how come the bone will become soft? As we already know that, due to, like, deficiency, and as we already know that vitamin D makes the bones hard. So when the deficiency is there, the bone will ultimately become soft. Okay. And the other, we can see some symptoms, deformities in the knee. One is a knock knee, and one is a bow knee, and one is a windswept deformity. So right over here you can see a windswept deformity, you can see over this, and here we have the x-ray. Okay. And the bow knee you can see over here, this is found in the children's, in rickets. This is the bow knee. And the next point is the E stands for end of long bone widening. So the long bone which are being widened, it will be stopped due to deficiency of vitamin D. And in teeth we can see a delayed eruption, like growth of the teeth. And other is hypoplasia. Right over here you can see the hypoplasia, severe enamel hypoplasia, which is seen in the kids right over here, this. Okay. And there are other deformities which we can see in the skull. So first and foremost is frontal blossing. So right over here we have a picture of frontal blossing. You can see over here the frontal bone is pushed outwards due to a soft bone. Okay. And the other thing is delayed closure of frontanels. Means what? It is a space between two sutures, like we can say that these are the two sutures. Okay. Hmm. So they are like this space, from here we have the bone, here we have the bone. So what will happen, there will be a more space, there will be a delayed joining of the bone. Okay. And then we have the widening of sutures, the sutures will be widened. So as we already know, this is a suture. Okay. So this suture will be widened between two bones. Here we have one bone, here we have one bone, so the space here will be widened. Okay. So why it will be widened? So we can see that due to increased intracranial pressure in infants and children. Okay. And here we have some pictures, like the bony in rickets. Okay. The rosette rosary. And here we have the x-ray about it. So now how will investigate this particular in children, particular deformity in children? So first and foremost we'll go with the x-ray. In x-ray we'll have three signs, which is the first and foremost is cupping. Cupping means what? The inward bulging of the metaphysis. So here, right over here, we can see cupping. And how inward? Like inward, this is the metaphysis. So here there is a inward. It's not like the complete proper growth. This is the complete proper growth. But here we can see the cupping. And the other is splaying. So splaying means what? The widening of metaphyseal end. So right over here you can see splaying. Okay. So this is the widening of metaphyseal bone. Right over here we can see. Okay. And the third one is the fraying. Fraying means what? The indistinct margins of metaphysis. As we already know that there should be a clear margin of metaphysis, but here we are unable to see. Here at the particular zone we are unable to see the clear margin. So for in the normal it will look like this, but we cannot see a proper metaphysis. Okay, the margins. And the other investigations which we'll be doing is a serum, like the will draw the blood from the patient and will send it for the investigation. So say there serum calcium will be observing. So serum calcium might be decreased or it might be a normal, but related to phosphate, the phosphate values will be decreased. Okay. And the parathyroid hormone, as we already know, this is a kid, so it has to be a hormones which are related to the growth, so it will be increased in ultimate way in order to compensate the deficiency of vitamin D. And other is alkaline phosphate, so alkaline phosphate will be also increased. So we have done the investigation. Now how will we manage the rickets in children? So in management we have a oral vitamin D therapy. Okay, for kids. And if there is an infant, we can give the serum and all those things. So there are two particular classifications, one is high dose and one is low dose. So in high dose what happens is, in high dose it is for a short duration. Like in short duration, if you want to achieve a particular the reference or biological values of the vitamin D, so we'll go with the high dose, which is a STOS regimen. So in this what we'll do, we'll give a 60,000 international units of tablets for 10 days. And in low dose, which is a long duration period. Okay. So this is preferred for our practice, which will be vitamin D tablets of 2000 to 6000 international units per day for 12 weeks. Okay. And then we can administer calcium, if there is a decreased value, we can administer calcium orally, which is 50 to 75 milligram per kg per day. So we have to evaluate on depending upon the weight. Okay, so this we saw about the uh, vitamin D deficiency in children's, and now let's look into the adults, what happens in adults. Okay, so in adults, what happens is deficiency will lead to osteomalacia. Osteomalacia will be seen in adults. So what it will do, it is an impaired mineralization of bone matrix. Okay. So like what are the causes? So the causes will be decreased uptake of vitamin D, there will be a malabsorption, there will be a decreased vitamin D metabolism, a decreased phosphorus, renal tubular acidosis type 1. Okay. So these are the causes of vitamin D in adults, deficiency in adults. Okay, and next we have the clinical feature. What are the clinical features that will be seen in adults? So first and foremost, we'll have the bone pain, then we'll have the fractures, more fragile to fractures, and then we have ataxic gait, muscle weakness, lethargy, and then we have collapse of vertebrae due to like overburdening of it, and deformities will be kyphosis, and there is coxa vera, pigeon chest. These all clinical features will be seen in adults. Okay, so now in adults, what will be the classification? Not classification. What will be the investigation? How will we do? So we'll take an X-ray. So there we can see some the signs. Okay, so first and foremost will be decreased bone density, and then we will have the thin cortex, and then we have radiolucent bands, which is pseudo fractures. Okay, which is also known as Looser's zone. And for serum, blood investigation will carry on same as the kids. The calcium, which will be decreased, or normal phosphate will be decreased, parathyroid hormone will be increased, alkaline phosphate will be increased as well. So now how will do the management of vitamin D deficiency in adults for osteomalacia? So first and foremost, we'll administer tablet vitamin D, which will be 1000 to 4000 international units for 3 months. Okay, and which should be taken with a fatty diet to increase what, to increase the absorption. Okay, and then if the condition is due to malabsorption, if we diagnose some or the other way for the malabsorption, then we'll administer vitamin D 50,000 to 1 lakh international units with calcium, with the same regimen for 3 months, and tablet calcitriol 0.5 to 1 milligram daily. Okay, and if that person has a chronic kidney disease, okay, so at that time we'll administer tablet calcitriol 0.5 to 1 mg daily. Okay, so thanks a lot for watching this video. I hope you understood, and these notes are available for free without any cost. I'll just pin it down in the description section, and don't forget to like, share, and subscribe, and do support. And thanks a lot for watching this video.